Hello, and thank you for joining us for the sixth annual Global Summit on Kidney Disease Innovations. Vox Populi, the time is now to prevent and cure kidney diseases. This summit is hosted by the American Association of Kidney Patients in partnership with our allies from the George Washington University School of Medicine and Health Sciences. My name is Fiona McKinney, and I'm an AAKP National Ambassador. I'm originally from Dublin, Ireland, and have been living in New York for the past 30 years. I am also an in-center hemodialysis patient since 2008. I was diagnosed with glomerulonephritis when I was 16 and emigrated to New York in my early 20s to find help with the disease. I stabilized my condition for over 20 years before things changed again in 2008 when I ended up on dialysis. Being part of the AAKP since 2016 has allowed me to be with people who truly understand the challenges and difficulties of living with kidney disease. As a member, AAKP offers me a voice not just for myself, but also for other kidney patients through programs and events like this Global Summit. This year's Global Summit theme, Vox Populi, was purposely and strategically chosen by AAKP for its historical meaning, voice of the people. I am one of the people who has chosen to raise my voice in support of greater care choice and innovation in kidney care. And I am one of the voices demanding a change in status quo kidney medicine. Over 850 million individuals across the world have kidney disease. This number is increasing at an estimated rate of between 5 and 7% annually. Every year we lose thousands of innocent lives to preventable kidney issues and the lack of timely access to treatment. AAKP believes kidney disease is both a workforce and healthcare issue. The disease takes a devastating toll on human lives and livelihoods. Most people understand that kidney disease left undetected and untreated can lead to premature death, but many are not aware that it impacts a person's dignity and ability to provide for themselves and their families. Kidney disease and outdated treatments can lead to unemployment, underemployment, disability, and dependency. In 2019, AAKP declared the next 10 years the decade of the kidney. The time is now for kidney patient consumers, healthcare professionals, researchers, industry, and all people of goodwill to unite our voices and demand change. We are optimistic that we can and will save more lives, but to do this, we must demand new screening guidelines and diagnostics, new biologics, and new devices. Together, we can manage and solve this growing global public health crisis. The time is now for elected and appointed leaders worldwide to listen to patient voices. Governments must remove the regulatory and payment barriers they create that delay innovation and prevent timely care access. If the government fails to act, we must raise our voices and demand an end to negative government detriments of health. Every nation is impacted by kidney disease, and millions of people are at risk. The optimistic news is that every person watching this program today can help those impacted by kidney disease and have an effect within their own nation. Through AAKP Global, AAKP is educating patients, care partners, healthcare professionals, and policy leaders across the world on unmet patient needs. Our annual Global Summit on Kidney Disease Innovations has helped put a human face on what is now the 10th leading cause of death based on data from the World Health Organization. We've connected people across the globe in a common purpose that is larger than any one person or nation. Together, we have increased hope and optimism. So thank you for joining us. Your voice is the voice of the people, and you can count on AAKP to keep amplifying it throughout the world to create change. With that, I'm honored to serve as the moderator for our session entitled Advancements in Dialysis Care, Incremental versus Conventional Dialysis Treatment. We have two esteemed speakers for this session. I'm excited to welcome them both, Dr. Giorgina Piccoli and Dr. Mariana Murea. Dr. Piccoli is an associate professor in nephrology at the Université at Angers, France, and head of the nephrology unit at Centre Hospitalier Le Mans, France. Dr. Piccoli is renowned for her innovative research, clinical expertise, and dedication to educating future medical professionals. Her work continues to make a significant impact on the global nephrology community. Joining her is Dr. Murea, an associate professor at Wake Forest University School of Medicine in North Carolina. Dr. Murea specializes in clinical research in hemodialysis. She serves as the lead principal investigator of a patient-centered outcomes research institute that serves as a national-funded, multi-center clinical trial. This trial compares individualized, incremental start hemodialysis with conventional hemodialysis, reflecting Dr. Murea's commitment to advancing patient-centered care and improving outcomes for those undergoing hemodialysis. Please join me in welcoming Dr. Giorgina Piccoli and Dr. Mariana Murea. I turn the program over to you both.
Thank you, Fiona, and thank you, AAKP and George Washington University for giving me the opportunity to speak at this year's AAKP Global Summit on Kidney Disease and Innovations. Today, Dr. Piccoli, Giorgina Piccoli, and myself will talk about incremental hemodialysis as a patient-tailored approach to treatment with chronic hemodialysis. And before I begin, I want to express how honored I am to share the platform today with Dr. Giorgina Piccoli, who is a world-renowned clinician, scientist, and a pioneer of incremental hemodialysis. Our presentation is focused on what we know about incremental hemodialysis and what needs to be done to make incremental hemodialysis an option for all eligible patients. So we will begin with examining the current approach to initiating chronic hemodialysis, which is that of thrice weekly conventional hemodialysis. Then we will present what is known about a different approach to how to initiate chronic hemodialysis for patients who have residual kidney function, which is that of incremental hemodialysis. And in the end, we would outline milestones that need to be overcome to make incremental hemodialysis a viable option to all eligible patients. To illustrate the current approach on how we prescribe chronic hemodialysis, I will begin with two canonical examples of clinical encounters between kidney patients and kidney physicians. First example involves a patient with a history of chronic kidney disease who is now at a point where signs and symptoms attributable to advanced kidney disease are no longer controlled with medications and diet. And patient had elected in-center hemodialysis as the preferred dialysis modality. And the physician recommends initiation of chronic hemodialysis and prescribes thrice weekly hemodialysis, each session to be delivered at the preset minimum intensity. Before the encounter ends, the patient says, "Doc, I still make quite a bit of urine," yet that statement does not change how the physician prescribes initiation of chronic hemodialysis. Second example involves a patient who has been on chronic hemodialysis for years. This patient makes less than half a cup of urine a day. The physician assesses the blood test results, volume management, and blood pressure, and continues the same recommendation of thrice weekly hemodialysis, each session delivered at the same preset minimum intensity as in the former case. So let's take a step back and ask, when it comes to deciding the prescription of chronic hemodialysis, how much does it matter whether the patient is just starting chronic hemodialysis and has appreciable urine output, which we call residual kidney function, or whether the patient has been on hemodialysis for years and has minimal urine output or very low urine output? The answer is it does not matter in the current state of hemodialysis practice. By and large, the approach to chronic hemodialysis prescription is single-minded. And when it comes to prescribing chronic hemodialysis, patients' place in disease trajectory has little bearing. And chronic hemodialysis is prescribed as thrice weekly hemodialysis, each session of 3 to 4 hours. And this approach has been named conventional hemodialysis. Now, the legacy of conventional hemodialysis has borne out of two randomized controlled trials that compared conventional hemodialysis with lower intensity hemodialysis. In this slide, these randomized clinical trials are shown by names NCDS and the HEMO study. A crucial aspect of these clinical trials is that it involved only patients who had been on hemodialysis for some years and who had minimal residual kidney function equivalent to less than half a cup of urine output a day, or a glomerular filtration rate less than 5 mLs per minute per body surface area. In other words, only for patients comparable to the second example I just gave was conventional hemodialysis studied and deemed to be the hemodialysis intensity that is associated with better outcomes than lower intensity hemodialysis. But patients with residual kidney function comparable to the first example I just gave were excluded from these two paradigm setting randomized controlled clinical trials. Yet when it comes in real world practice, all patients who start in-center hemodialysis, they are prescribed thrice weekly conventional hemodialysis, whether they have or don't have ongoing residual kidney function. However, some patients who do require chronic hemodialysis initiation still have appreciable levels of urine output, which again we call residual kidney function. From a kidney disease progression standpoint, not all patients who transition from making an appreciable amount of urine to making less than a half a cup of urine, that transition doesn't happen over a span of a few days or a few weeks, but rather many patients who start dialysis still have some level of residual kidney function, although that residual kidney function indeed continues to decline after dialysis initiation, as it also did, as the kidney function also was on a steady decline before dialysis initiation. And this concept of patient finding themselves on a continuum of kidney function levels before and after dialysis initiation is illustrated in this schematic. In the United States, about 40 to 50% of the patients have an estimated glomerular filtration rate that is 7 or 8 mLs per minute per body surface area, which indicates the presence of appreciable residual kidney function, as this is based on the data from the United States renal data system shown in this left-sided figure. Now, let's contrast the approach to prescribing chronic dialysis between a patient who elects peritoneal dialysis and that who elects hemodialysis. When a patient chooses peritoneal dialysis, residual kidney function is measured, and the prescription of peritoneal dialysis is adjusted based on clinical needs, which are often driven by underlying residual kidney function levels. As residual kidney function level after dialysis start declines, the prescription of peritoneal dialysis is augmented. When a patient chooses hemodialysis, residual kidney function is not taken into account, and the hemodialysis prescription is always the same: thrice weekly conventional hemodialysis, whether they have or don't have residual kidney function. In fact, if a patient on peritoneal dialysis were to change their mind and a few weeks into dialysis treatment switch to hemodialysis, their residual kidney function would be completely disregarded. In the peritoneal dialysis community, the value of residual kidney function has been recognized since 2002, and the residual kidney function has always been incorporated in the prescription of peritoneal dialysis. And most remarkably, in 2020, the PD clinical practice guidelines, the peritoneal dialysis clinical practice guidelines, recommended individualizing the prescription of peritoneal dialysis based on clinical symptoms. In other words, the peritoneal dialysis prescription does no longer need to be increased or augmented based on clearance metrics alone. In contrast, though, with hemodialysis, residual kidney function is not measured or not checked, not asked about, and the hemodialysis prescription needs to be increased if clinical metrics are not, clearance metrics are not met, regardless of patient's symptoms, regardless of patient's residual kidney function or course of care. One might ask, are we prescribing the same hemodialysis intensity to patients with residual kidney function based on evidence of benefit with conventional hemodialysis on top of the present residual kidney function? And the answer is no. And the answer comes from many studies, but the first large study to have answered this question is that of the Netherlands cooperative study in 2004. And the Netherlands study showed that the relationship of lower hemodialysis dose per week with poorer outcomes. In this study, the outcome of interest was mortality. That relationship between the lower hemodialysis dose and poor outcomes was present only in patients without residual kidney function, as shown here in the right-sided group of columns. But the relationship between the hemodialysis dose per week and mortality was not present in those with residual kidney function, as shown here in the left side group of columns, meaning mortality did not increase with lower hemodialysis intensity per week when patients had residual kidney function. So we and others argued that the hemodialysis needs for patients who have residual kidney function at dialysis initiation differ than the hemodialysis needs of those patients who were included in the 2 clinical trials of conventional hemodialysis and who have no or very low residual kidney function, such as less than a cup or half a cup of urine a day, or a glomerular filtration less than 5 mL per minute per body surface area. So patients who have residual kidney function at dialysis initiation, we argued that their needs of dialysis are lower, and we should be able to individualize the hemodialysis prescription, starting with lower treatments or fewer treatments of hemodialysis that complement the clinical needs, which are often determined by their level of underlying residual kidney function and comorbidities. So in this manner, for the first example I presented, chronic hemodialysis could start with either once or twice weekly hemodialysis, depending on the clinical scenario, and then it would be increased to more frequent hemodialysis according to clinical needs. And this approach is called incremental hemodialysis. For the second example that I presented, or patients who fall in that category, chronic hemodialysis could be continued according to the conventional formula, and some patients who may have large volume gains or difficulty with attaining good volume status between dialysis treatments may even need an occasional or standing fourth hemodialysis treatment per week. In other words, the hemodialysis prescription should be individualized at all stages of dialysis transitions. So incremental hemodialysis recognizes that patients with kidney disease are on a trajectory of continued deterioration of kidney function, both before and after hemodialysis. And it consists of starting with less intensive or less frequent hemodialysis and gradually increasing over a span of weeks or months or years, depending on each patient's clinical manifestation, to more frequent or more prolonged sessions of hemodialysis. And these needs of growing needs of hemodialysis treatments are driven by the decline of residual kidney function and comorbidities. The incremental hemodialysis can be applied to both in-center and home hemodialysis, and most of the experience in literature, though, as of today comes from patients who had been treated with in-center hemodialysis, which is why most of the data that we are presenting over the next slides comes from patients who were treated with in-center incremental hemodialysis. It is very important to point out that incremental hemodialysis is not a new concept. Back in 1960s and early 1970s, patients with very advanced kidney failure were started on hemodialysis as one treatment every 5 to 10 days. And when symptoms of uremia or advanced symptoms related to advanced kidney failure reappeared, hemodialysis was increased to one treatment every 5 to 3 days. So twice a week hemodialysis was usually considered as the maintenance hemodialysis prescription. And even at that time, the pioneers pointed out that when uremic complications reemerged or neuropathy developed with infrequent hemodialysis, it was largely the result of residual kidney function deterioration. And there is no reason to assume a priori that every patient requires 3 instead of 2 hemodialysis treatments per week when chronic hemodialysis is started. But those observations were not considered when the conventional practice of thrice weekly hemodialysis formed in the mid to late 1970s. Ever since, chronic hemodialysis has been made available to all patients who need dialysis. The adoption of incremental hemodialysis has varied worldwide. Some centers have consistently practiced clinically indicated incremental hemodialysis, accumulating decades of data demonstrating favorable outcomes. Notably, centers in France, Italy, Spain, and Switzerland fall into this category. This is not to be confused with the delivery of less frequent hemodialysis in settings of resource scarcity. Next, I would like to invite Dr. Giorgina Piccoli to share her and her team's insights and expertise on incremental hemodialysis.
Thank you, Mariana. It's a pleasure to be here talking to the Global Summit on Kidney Disease Innovations. The word innovation is so important. Dr. Murea asked me to talk about what is known about an alternative approach to initiating treatment with chronic hemodialysis for patients who have residual kidney function, that is, incremental hemodialysis. Scared, I will not speak about what is known, but more humbly, I will try to say what we know and give you some insight into a European experience. Incremental hemodialysis is not such a new idea, especially in Italy. Maybe because we Italians tend to have a flair for personalization. We are usually known to be musicians, make the best pizza, and have a lot of invention. But actually, the personalization of treatment is a part of our medical culture since, I would say, since I studied, since the 80s. And in a way, we were somehow reluctant to adopt the more standardized procedures also on dialysis. And I loved watching back to 2 papers that I had pleasure of writing when I was much, much younger. Maintenance of residual kidney function 10 years after the start of hemodialysis and hemodialysis a la carte tailor-made program. That was a paper that is now 20 years old. The first story is a story that is rather interesting. A 58-year-old patient who started the dialysis in 1994. He was normotensive. He most probably had an interstitial nephropathy linked to some inborn error of uric acid handling. As you may see in this Russian mountain graph, where we measured all what we could, urea clearance, creatinine clearance, and ureasis, he had passed through many swings of kidney function, started three times per week, then get back to 2, scaled to 3, spent many years on twice weekly dialysis, then some time on once weekly dialysis and twice weekly and once weekly again. And then finally his residual kidney function started increasing. But it was 10 years. And I think one message is very important in this graph. There is no single measure. Now we are trying to standardize incremental dialysis, but the reason for skipping from 1 to 2 to 3 to 2 to 1 sessions was not just the urine output, was not just the urea clearance, was something more comprehensive. If not, this patient who lived about 20 years on dialysis would have probably remain on 3 times per week all his lifelong. And this is a very busy graph, but when I was young, I got the possibility of restarting a home hemodialysis program. And I was impressed by seeing that we even used 20 years ago, the paper was published in 2003, the term incremental dialysis. And the patients used a mix of more frequent and less frequent dialysis that was really adapted to the needs, the residual kidney function, and overall the way of life, also the need of dialyzing for less hours more frequently because they were working, and so on. And the age range was pretty large, from the 20s to the 70s. I love these warm going upstairs. It's not by chance that John Agar, the inventor of the idea of green dialysis, was fascinated by the incremental dialysis approach that was not so near the Australian way of prescribing dialysis, considering also how better for the planet this is. But let me say that the idea of personalization of dialysis was well embedded in the Italian tradition of personalized approaches, not just to dialysis, but also to nutrition in the pre-dialysis phase, dialysis choice and schedules, but also post-transplant treatments. In France, where I moved 8 years ago, the experience of Tassin, Guy-Laurent with long-hour dialysis, which remained a niche for several decades, set also the stage for a more flexible and tolerant approach to personalization of dialysis. And the same concepts of tailored approaches to chronic treatments are now exemplified, as Mariana said in the guidelines for peritoneal dialysis. Tailored hemodialysis is not a new idea. 1992, Bernard Charrat published this paper that was cited more than 1,000 times, Survival as an Index of the Efficiency of Dialysis. It was the moment in which everybody was looking at KT over D, and he said, now let's look at the hard outcomes. They dialyzed 8 hours, 3 times per week, mostly at night. And their survival data were amazing. But in the same period in Italy, Umberto Buoncristiani, the inventor of a white set on peritoneal dialysis, had started an experience with short daily hemodialysis, the first large one worldwide, just for helping his patients to cope with their life. And I like this figure 1. It's still drawn by pen, by hand, in which in 61% of the cases, the reason of choice was patient's preference. So when I came to France, I had a fantastic background, but I was also lucky. The first patient that we started on incremental dialysis was a success. Was Mr. H, deep countryside, Madame Piccoli. He was coming 90 years old, still having his garden and his potatoes. And no one wanted to start him on dialysis because he was 90 years old, it was fragile. So we discussed with him and we ended up with a schedule of 2.3 hours once weekly. low permeability membrane, low blood flux, moderate weight loss, erythropoietin once weekly, weekly blood test, and this lovely patient lived 4 years. He died quietly in his bed 4 years later, after having been hospitalized only twice over 4 years. And actually, the success of this patient was a key for the development of incremental dialysis in our center. Recently, we put together the experience of 2017-2021, where 158 patients started hemodialysis in our center, and roughly 2/3 of them were able to benefit of incremental and decremental schedules, and only 1/3 of them started and continued on conventional schedules. While patients on standard schedules had lower initial eGFR, it's also true that in this group, there are many patients that started the dialysis in emergency or anuric. But we found no survival differences according to the period of start, considering the patients of a French registry. And our patients that were started, I will get back to these, with pre-dialysis care, intensive pre-dialysis care, had more chances to benefit of an incremental start. The cost savings for the society are very important, but we will get back to this. The first question we wanted to answer was if we were killing these patients. And actually, no difference in our center between standard and non-standard schedules, and no difference with the RAIN registry and the incremental patients. And how long does this last? For half of the patients, 1 year, and there is a 25%, 1 patient out of 4 goes on for longer, for 2-3 years on incremental, less frequent schedules. Les jeux sont faits. The games are done in the pre-dialysis phase. This is probably one of the most important slides and one of the most important findings of a study that has been further confirmed with new data, not published so far. Patients that are followed up with so-called intensive pre-dialysis care have 10 times more chances to start on an incremental schedule. But if patients are metabolically stable, their chances to have a smoother dialysis start are much higher. Similar results have been found by an Italian group that we were very happy to see that they sort of cited our title, and they pretty much found similar results, both in terms of survival and in terms of duration of incremental hemodialysis. And also our colleagues from Switzerland found pretty much similar results. But let me say that the problem of the differences is the case mix. Patients that start an incremental dialysis are probably more balanced and better cared for than patients that start on thrice-weekly dialysis, and accounting for comorbidity is always very, very different and very, very difficult, because comorbidities are just general labels, but the severity of comorbidity is very high to be taken into account. But overall results are at least as good as those of patients that start on thrice-weekly hemodialysis. How to prescribe it? There are basically 2 ways. One way is by the numbers, and one way is based upon clinical manifestations. By the numbers, it's urea clearance, but I have to say that there is no randomized study, no real titration study about that. It's a wise opinion based upon experience of few groups, but it's very easy to replicate. And that is now becoming the rule. Make urea clearance if it's more than 3 milliliters per minute for 1.733 square meters, then you can start once. If it's between 2 and 4, 2 times, and it's very low, you can start 3 times per week. I think that all of us who practice incremental dialysis would agree that there is no absolute level of residual kidney function that dictates the step up in hemodialysis, but it's the overall clinical picture. And indeed, this is what we do. We consider that incremental dialysis start should be done unless contraindicated. And of course, in anuric patients will not benefit of it. Of course, a patient who has a high volume overload is not likely to benefit from it. Some patients with high metabolic needs and some young patients may be more difficult to stabilize unless they have, like the first case I showed you, an interstitial disease. And if a patient is terribly malnourished, there is something wrong. So it's not, dialysis will probably not fix it. Maybe more dialysis, at least in the beginning, can be useful. And non-adherence to medical prescription, well, yes and not. Sometimes patients become more adherent to medical prescription if they understand that you're working with them, for them, and we are trying to understand them as single individuals. Do we always need urinary 24-hour urine collections? We have a very old high comorbidity population. But we also know from studies on lithiasis in younger patients that less than half of the urinary 24-hour urinary collections are really reliable. So we use also beta-2 microglobulin based formula that had been originally suggested for peritoneal dialysis, and we use a rather smooth dialysis prescription on incremental hemodialysis. And actually, this is just stretching the intent to defer strategy that is integrated in the guidelines since 10 years. Canadians were the first ones that suggest not to start dialysis too early, according to the results of a fantastic ideal trial that showed that what we call the healthy early initiation of dialysis is not so healthy for the patient and for the society. When we looked, this is a thesis of one of our students, not published so far, when we look at the reasons to start dialysis and to increase frequency, overload and hypertension are two of the most important ones, but for starting dialysis, fatigue has also a great role. But more than that, even if biochemical data are important, in most of the patients, there are more than one reason put together that make us decide that's a good moment for starting dialysis. So to try to summarize this part, I hope to have discussed with you that incremental hemodialysis start may represent a real new standard of care. 2/3 of patients in our setting. It's safe and feasible, at least in our European population with advanced age and high comorbidity, but also with an intensive pre-dialysis follow-up. So we may suggest to reverse the paradigm. Instead of trying to identify the ideal candidates for incremental dialysis, we should probably focus on reducing contraindications, and we should focus. I really think that we have to invest on pre-dialysis follow-up. The clinics is for us more important than the numbers. The decision on when to start dialysis after the ideal study have been rephrased to this intent to delay strategy with attention to signs and symptoms and not just numbers. And we hold that exactly the same approach may be employed for modulating dialysis frequency. And with this, I will leave again the word to Dr. Mariana Murea, a great nephrologist, and a friend. The floor is yours.
So in the last part of the talk, myself and Dr. Piccoli will outline the milestones that need to be overcome to make incremental hemodialysis a viable option to all eligible patients. The adoption of any clinical intervention depends on three pillars: the clinical evidence or the science behind the intervention, the clinical practice guidelines, and the policies and reimbursement as they pertain to intervention delivery. So let's look at each pillar for incremental hemodialysis. First, we begin with the pillar of science or evidence behind incremental hemodialysis. What has the science overall shown in terms of the safety or beneficial effects for the patient? Well, a meta-analysis of 22 observational studies, which included data from Dr. Kalantarzade's experience in California, and 2 pilot feasibility studies, which included data from Dr. Villar's experience in the United Kingdom and my experience in North Carolina, concluded that patients treated with incremental hemodialysis and those treated with conventional hemodialysis had a similar outcome of survival. And in fact, there was a trend toward fewer hospitalizations in patients treated with incremental hemodialysis. So the evidence overall says that the incremental hemodialysis is safe when it's practiced as a form of clinically recommended incremental hemodialysis, not due to the setting of resource restrictions or resource limitations. For the patients, incremental hemodialysis brings obviously several lifestyle advantages. In Australia, Haggerty and Vicelli and their collaborators held focus group meetings with patients with chronic kidney disease, and the patients stated that they preferred an incremental start to hemodialysis to minimize disruption to daily living and reduce the negative impacts on their ability to work. In the study we did in North Carolina, patients on hemodialysis reported fewer symptoms of anxiety and depression during this period of twice-weekly hemodialysis than after they were transitioned to thrice-weekly hemodialysis. For the second pillar, clinical practice guidelines have put a growing emphasis on the residual kidney function as a component that contributes to the overall dialytic needs for patients on hemodialysis. Without going into technical details, it is notable that the latest guidelines in the United States, published in 2015, have augmented the contribution of residual kidney function when calculating the per-week hemodialysis requirements. Certainly, incremental hemodialysis has also been endorsed by European guidelines published in 2019, 2020, and 2023. And finally, the third pillar, that of policies and reimbursements. And unfortunately, the current policies and reimbursements significantly hinder the study and the practice of patient-tailored dialysis. For example, reimbursement for hemodialysis is tied to the frequency of treatments, achievement of biochemical quality metrics, and meeting a minimum hemodialysis clearance treatment. And reimbursement for peritoneal dialysis is tied to meeting weekly clearance metrics. So therefore, physicians must augment dialysis prescription to meet a predetermined set of metrics, even if the patient feels well. For example, if for patients treated with peritoneal dialysis, not meeting a certain weekly clearance goal has impact on the reimbursement of the dialysis providers. And in the setting of incremental hemodialysis, delivering fewer dialysis treatments is also associated with a lower reimbursement for the dialysis providers. So both the physicians and investigators have significant limitations on how they can apply or study the incremental dialysis, because it endangers financial viability of the dialysis services. presently, so that the strengths of these three pillars are not solid enough, and due to all the weaknesses that are in this pillar, some of which are perceived and some of which are real, the option of incremental hemodialysis has not been available for patients with residual kidney function. Some believe the evidence behind incremental hemodialysis, so the scientific evidence is not compelling enough to deem incremental hemodialysis as a viable or safe option for patients with residual kidney function. Some also believe that the clinical practice guidelines for incremental hemodialysis are not as rich or well crafted as those for conventional hemodialysis. And certainly the current policies and reimbursements are not conducive to an incremental patient-tailored prescription of dialysis. So what can be done? For the pillar of scientific evidence, some think that head-to-head comparison between incremental hemodialysis and conventional hemodialysis is needed to prove safety with the approach of incremental hemodialysis. Thus, randomized controlled trials that compare the effectiveness of incremental hemodialysis with that of conventional hemodialysis that are being conducted in Spain, Italy, Australia, and Canada. In the United States, Dr. Kalantar Zadeh and his collaborators are conducting a clinical trial in the veterans population called the INCVET trial. And myself and Dr. Kotanko and many passionate clinical investigators across 9 healthcare systems in the United States are also conducting a randomized controlled trial called the 2+ trial across more than 40 dialysis centers that span 4 dialysis organizations in the United States. It must be said, though, that conducting these studies is challenging in the current reimbursement climate because doing incremental hemodialysis poses risks of financial instability for dialysis services. But we hope that these clinical trials can be successfully accomplished. Regarding the pillar of guidelines, this would need to provide more guidance and improve clarity on the practicalities of incremental hemodialysis. Ideally, there should be one set of clinical practice guidelines consolidated across continents and written by an international group of experts in incremental hemodialysis. And finally, but most importantly, one could argue, policies and reimbursement formulas must be amended to align with patient-centered care while ensuring the economic health of dialysis services.
Dr. Murea told a lot about incremental dialysis. What can we add from the European point of view? 3 small points, some further considerations on the difficult relationship between randomized controlled trials and personalization, a few considerations on costs, and I would like to add a few comments of our patients and nurses that are confronted every day with our crazy personalized schedules. In a way, incremental dialysis is a paradox. It has many advantages for the society: fewer dialysis sessions, lower cost per patient, less need for transportation, more patients in the same center, so a reduced need for new structures, and this is fantastic for the society. And it's probably also very good for the patient. But the hospital, the provider, is disadvantaged. More complex organization, higher cost of tests for patients because we need, at least we think we need, stricter controls, and fewer sessions, but these sessions are not so simple. So to try to understand, to make my direction, economic direction, understand the difference, I copied it in French, but I think you will understand it. We ended up with the little pigs. In the dialysis bundle, the forfait, there are the tests, some of the drugs, the controls, the dietary controls, the physical activity, the secretary activities, and also there is our presence. We are reimbursed per session. If we have 3 sessions per week, all these things that are in the bundle weight on 3 sessions, in a way are divided by 3. If we make just 2 dialysis sessions, these are divided by 2. But if we make only 1 dialysis session, this session will have the physician, the dietitian, the controls, everything, and the test, and the erythropoietin, and everything. So it's a more expensive session. And let me also say that we are now treating 150 patients on the same number of dialysis beds we used for 100. So we would need one more full-time nephrologist and more. So what's good for the patient, what's good for the society, is not always good for the provider. And indeed, this is probably one of the main hurdles that make so difficult to implement incremental hemodialysis. Well, it seems so easy to use personalized guidelines, as Mariana said, on peritoneal dialysis, considering the patient, considering the individual. Well, also probably, at least in Europe, because peritoneal dialysis is paid by week of treatment. No matter if a patient makes 1 exchange or 4 exchanges. So economically, it's much easier and it's much more appealing to have incremental PD than incremental hemodialysis. Prescribing is an art and it's difficult. I absolutely love this figure of the complexity of care when prescribing high-quality peritoneal dialysis. There are two points to be underlined. The first one, that if you have so many potential elements to consider, functional status, social, patient-reported outcomes, residual kidney function, volume status, anemia, bone mineral disorders, nutrition, metabolic parameters, membrane function, etc. And not just the numbers that exist but are in the end. And you have to cope with individuals. You need more medical time. You need more time. But it's feasible. It's possible. It's possible also to build guidelines on that. And this is what we tried to do in nutrition. I asked for permission to Dr. Brown to use her graph and adapt it to diet, showing that we do not need to have rigid guidelines based on numbers. We may also have indications based on comprehensive clinical assessment. But let me close with a small series of interviews. I owe Mariana the fact of having done, asking some of my nurses and one of my best friends, who used to be one of my patients for more than 20 years, about incremental start. The answers of our nurses were, in the beginning, it was strange. We were surprised. We were used to standards. We were scared it could lead to underdialysis. We were obsessed by the frequent monitoring of blood tests. The advantages are more comfort for the patient, time to adapt, to learn, for the elderly, better quality of life, and for the young ones, better integration with work. The drawbacks are for us, more complex organization, need for more attention, possible competition with peritoneal dialysis, and more complex to explain with regard to home hemodialysis. The ideal patients are probably at the extreme, very old, and very young, who need to live life. Would you get back? And they said, absolutely no. It's more logical, and now what we are used and know that how to do it, we would feel uneasy to start with too much dialysis. And would you start the dialysis incrementally? Yes, for sure, they all answered. And Rossella, my friend, well, she get back with another question. Do you know a better way to start dialysis? Thank you for listening to me, and I will leave the last words to Mariana.
So I would like to summarize that for decades, conventional thrice-weekly hemodialysis has been prescribed to all patients who start chronic hemodialysis at a similar frequency and a similar minimum dose, whether the patients have residual kidney functions or don't. Incremental hemodialysis is an option for patients with residual kidney function who have manifestations that can be managed with less intensive hemodialysis. Current reimbursements and practice quality metrics hinder the application of incremental hemodialysis or patient-tailored peritoneal dialysis that is endorsed by guidelines. Clinical investigators hope to study incremental hemodialysis and incremental peritoneal dialysis to bring more evidence that characterizes these dialysis treatment options. But changes in policies and reimbursement formulas are necessary to really make incremental dialysis available to all eligible patients. Thank you again, AAKP, and thank you, George Washington University, for having given me the space today to speak at the Global Summit of Kidney Disease and Innovation. Thank you so much.
Thank you, Dr. Giorgina Piccoli and Dr. Mariana Murea, for your excellent presentations. Before I let you go, I have a few questions for you both. I'd like to start with Dr. Murea. Can you tell me how you've incorporated the voices of the patients you serve in the design of your research around incremental dialysis?
Yes, absolutely. So this is actually a very important point because the primary outcome, so the main thing that we are focusing on in the study of incremental hemodialysis is driven by patients' preference to give attention to their outcomes of hospitalization and survival. So at the end, after we finished our first pilot study on incremental hemodialysis, we went and spoke with the patients who participated in that pilot study and asked them what they would want us to study first and foremost at a larger scale or a larger clinical trial. And so we give them, options between overall health status, such as hospitalizations or survival, as well as quality of life. And so for us, they said that they wanted to make sure that the approach is safe. So that's why our primary outcome actually in the main study, the main trial, 2+ trial, is a composite of all-cause ED visits, all-cause hospitalizations, and all-cause deaths.
More than that, we work together. We suffer together. We discuss together. It's a collaboration. We are lucky in Europe. We can care. Our patients can come to the hospital whenever they need, and everything we do, basically everything we do in Italy and France, is free of charge. So we become progressively the reference of all of them, and we discuss together. I remember one patient that did not want to start a dialysis because he had his income mainly comes from the working in the countryside, and there is the period of the apples, and so he had to work to pick up the apples, because it was a 2 months income that was fundamental for the winter. So we did dialysis on Saturdays once a week to let him work, and then finally increase the frequency of dialysis. It's just an example. We work together. We are the servants of our patients.
So my next question is for Dr. Piccoli. Can you tell our audience, given your international medical collaborations, is there a growing receptivity to the use of patient insights and lived experiences in kidney research amongst your global colleagues?
Well, this is a $100,000 million question. It's deeper than that. everything stems from the way we see patient-physician relationship. I hate, for example, the term healthcare provider. I'm not an healthcare provider. I'm a physician. I'm the physician of my patients. So if you have this kind of relationship, of course you integrate everything because you learn every day from your patients. You discuss with them, you try to listen, you try to understand, you try as much as you can, and it's always difficult to put your feet into their shoes. So there is no need to formally integrating things. If you spend time together, if you understand each other, if you become friends, if you are open enough to let your patients become your friends, in some cases, I mean, you're not friend with all your colleagues, but you're not friends with all your patients, but you can become friends with some colleagues if you're open-minded, and you can become friend with your patients if you are open-minded. So it's deeper. If you need to invite the patients to talk to you officially, this means that probably you did not listen to them in your everyday care. So I'm absolutely partisan for integrating patients in the choices, but I think that we have to be listening and humble enough to listen every day and to reflect every day and to build what we do upon what we hear every day.
Yes, actually, and I'm very thankful that there is this increasing awareness in the country and globally on the need to individualize treatments with hemodialysis, which in turn would respond to patients' needs, because their quality of life and their burden, the symptom burden, the treatment burden are great, are very high. So and raising awareness or having awareness not across the globe is definitely helping the scientists and the physicians who want to bring this option and make it more readily available to all patients who would be eligible. And definitely we hope that it's everything in the best interest for the patient, so in the patient's best interest. So yes, there is a growing awareness on this about this incremental hemodialysis as being a valid and safe option for patients who start hemodialysis, as long as they have adequate residual kidney function.
So I have one final question for both of you, and we'll start with Dr. Murea. Can you talk to our audience about the importance for both patients and professionals of growing collaborative networks together to increase clinical trial awareness, enrollment, and retention?
Yes, the strength of a clinical research, whether it's clinical trial or a prospective observational study, is to test the intervention across different clinical settings in different geographic areas, at different dialysis organizations. So absolutely, the more diverse and the more collaborative and widespread a clinical study is, the higher the value of the study. So that's one we've been focusing greatly on, getting as much of a diverse teams of investigators across the country, for example, for the 2+ study. And we're also trying to expand the diversity of dialysis organizations that participate in the study. We truly want to see how effective this intervention will be in various clinical settings.
Well, there is no other way. One of the reasons why there are so many legal actions against physicians is that people do not speak one with the other. This morning I was talking with a friend of mine who is a palliative care physician. And he was of great support when I accompanied one of my younger cousins to her last days. And she passed away in her home with all the family together. And it was a very important experience. And we were speaking about these. We have to stop also in the university teaching physicians that they are powerful, that they know, that they can decide. We are not there to heal. Everybody will die. We are there to understand, to help, to help everybody in this pathway that is life and that is disease. Of course, this needs to be structured, but it's not just physicians and patients. We have the nurses, we have the helpers. Sometimes the one who knows more secrets of a patient is the lady who makes the cleaning in the morning, because no one is scared of talking to her. And we have to have a different collaboration with the industry. We are there for the same goal, and that is not making money. There are many better ways to make money. We are there to heal people.
Thank you both for such great insights. We appreciate you, Dr. Piccoli and Dr. Murea, for participating in this year's Global Summit for Kidney Disease Innovations.